Hey, Dr. Lin, this is my initial project video. So going into some clinical history about my patient, he had a lot of right inversion ankle sprains. So this is a pretty significant inversion ankle sprain. He had a grade 2 injury, wasn't treated with any formal PT. After that, he had about 3 more inversion ankle sprains, but those weren't diagnosed. Same thing, no PT. Then he also had a right knee hyperextension, wasn't treated at all, just rest and ice. And then also some right patellar tendinopathy, also known as jumper's knee. As far as his movement history, he had 5 years of basketball, of competitive basketball, 12 years of recreational basketball, cardio kickboxing class, golf class, and weight training on and off for 7+ years, and then a pretty active job for 4 years. Current movement postures, currently in a tennis class, often complains of lower back pain, has all online classes, sitting postures all day, plays basketball recreationally, strength trains once, twice per week, normally upper body, sleeps on stomach with 2 pillows, which makes him go into a lot of spinal extension, and then works as a PT aid. In the deep squat assessment, he did pretty good in the sagittal view, no valgus of the knees, but his right knee did spin out a little bit, kind of indicating that dorsiflexion restriction. And then in the front of view, he does have that posterior pelvic tilt hypolordosis at the bottom of the squat, as we can see in this picture right here. From there, we went from heels up. So we can see in the heels up variation that the right foot does not spin out anymore, which is good. But you can see in the front of you that there is still that hypolordosis, posterior pelvic tilt, most likely due to overactive hamstrings, due to underactive glutes due to that inversion ankle sprain on that right side. We can see this in the still shot as well. For the hurdle step, there's a lot of frontal plane instability, a lot of hip hiking. The knee, hip and ankle do not stay aligned. There's some lateral flexion as well. And then we can see from the frontal plane view, there's some anterior pelvic tilt, and then a little bit of lateral flexion, and then a little bit of rotation of that pelvis as well. You can see these in the still shots as well. On the left side, same thing. There's a little bit of single leg instability. There was also some single leg instability on that last slide as well. I forgot to mention that. And then the hip, knee, and ankle also do stay out of alignment. And once again, losing the stability in the hips. The hips are hiking a lot, a little bit of lateral flexion. And then in that frontal plane view, once again, we see that anterior pelvic tilt, that hyperlordosis of the lumbar spine. And then also some rotation of that spine as well. We can see that in this still shot, where we can see that the pelvis is rotating to compensate to get that knee over the stick. So there is some lumbopelvic instability issues. For the inline lunge, we start in the foot is turned out, not in that straight line, which shows that once again, there's a compensation in that right ankle, which is the one which is the constant inversion ankle sprains. And then on the way down, there's a little bit of instability, a little bit of wobbling. And then there's also from the frontal plane view, we can see once again, there's that hyperlordotic posture of the pelvis, which kind of indicates overactive superficial hip flexors, tight superficial hip flexors, and then weak glutes as well. In the inline lunge on the left side, we can see that there is a little bit of frontal plane instability. That front foot constantly comes up off the ground, and then the hips kind of wobble on the way down. And then we can see from the frontal plane view, once again, those creases in the shirt kind of show that there is some hyperlordosis in that lumbar spine. And then just to note, the starting position, that right foot is also spun out once again. So another indicator for that dorsiflexion restriction on that right side. For the active straight leg raise, did a really bad job of getting the leg past the dowel. So that right hamstring is really tight, kind of going back to that overactive hamstring and that hamstring dominant hip extension pattern. So most likely due to underactive glutes from that right inversion ankle sprain. So once again, we can see not getting past that dowel, and then a little bit of daylight coming up off the plank right there. For the active straight leg raise on the left side, there's a little bit of a better job of getting the foot over or a little bit before that dowel. But unfortunately, in the frontal plane view, we do see that that right foot is kind of externally rotated out. That might be due to a compensation, or that might be just due to the instability in the ankle from the ankle sprain. But nonetheless, I do feel like there was some pain coming up here. So there is some tightness in that hamstring as well. For the trunk stability push-up, I'm actually the subject. So I've struggled a lot with the trunk stability push-up. As we can see in the sagittal plane, my hands are not in the proper position. I could not do the trunk stability push-up with my hands in line with the shoulders. So you do see me kind of warming my way up and then kind of crashing back down, not having that trunk stability at all. And then really bad in the frontal plane, I have a really bad anterior pelvic tilt of my lumbar spine. So there's a hyperlordosis of that spine, which shows that instability. And then when it came to the spinal extension clearing test, I actually did not pass that test because once I went into that spinal extension posture, it was really uncomfortable. So I did not pass that test. As far as the rotary stability, left to right, left arm to right knee, I did okay with this one as far as my rotary stability, but there is that glaring issue of the hyperlordosis posterior pelvic tilt with this exercise. So you can see the rounding of the back showing that instability of the pelvis. And then from the sagittal view, it doesn't look too bad. I do kind of maintain pretty good rotary stability, but I am a little bit unstable towards the end. The other side, similar issues as the last side. So we can see that once again, when I go through this exercise or this assessment, I'm going through that hyperlordosis, that posterior pelvic tilt, which kind of, once again, I think is due to the overactive hamstrings and the hip extension pattern. And then this is the sagittal view, just kind of showing the same thing. Pretty good rotary stability, but once again, that hyperlordosis is not good. And for that spinal flexion clearing test, I did pass that test and I felt pretty good. So it kind of lets me know that I'm probably extension intolerant in my lumbar spine. As far as my shoulder mobility assessment, this is the length of my arm. It's about 7.5 inches. And then these are both the measurements for my right and left arm. But unfortunately, this one's about 9 inches and this one's a little bit under 11 inches. So definitely lacking some mobility in that shoulder. So I'll definitely have to work on that during the corrective exercises. And then for the shoulder impingement clearing test, I actually did not pass that test. There was a little bit of discomfort as I was going through that test. So I did not pass that test. I wanted to add some hamstring stretches just to kind of see if it really is the hamstring that was tight and not my superficial hip flexors. So providing some proximal stability to the core. As you can see in this video, my hamstring was not able to get all the way up to 90. So we can see, come on, play. We can see on this side that, oh no, it's not playing, crap. Okay, so anyway, on the left side, we can see that the hamstring was not as tight. It wouldn't strain all the way, but it is a little tight. But if I can get this video to play, come on now, there it is. We can see that my right hamstring will not strain all the way, showing that it is in fact a hamstring flexibility issue and not a pelvic control issue. I also implemented a single leg RDL. On the right side, you can see that I do not have that full range of motion. That stick's gonna come up off the back. Yep, this is probably due to my over tight hamstrings and then a little bit weakness in the glute max as well, not being able to let me to get to that full position. And then we can see here that as I come down, my knee goes into a little bit of valgus, and then I'm obviously lacking some single leg stability as well. That right foot is also turned out, once again, showing that dorsiflexion restriction. Moving on to the other side, I do a little bit better on this side. I'm able to get more parallel and the stick does maintain full contact on the back the whole time, but I do kind of lack that end range motion. I think that hamstring is pretty tight back there. So I don't get that full range of motion. And then from the sagittal plane view, we can see I'm lacking a little bit of knee single leg stability, but no real knee valgus like the right side. And then as far as my movement compensations and my corrective exercises, to treat my ankle spinning out, I'm gonna prescribe myself some ankle dorsiflexion mobilizations to break up any scar tissue, and then the worm walk plantar flexion stretch to lengthen those plantar flexor muscles. For my hypolordotic and posterior pelvic tilt postures, I obviously want to get the glute max activated again, so the hamstrings don't have to overcompensate for that. So for that, I'm going to do some banded glute bridges, sagittal plane banded walks, single leg RDLs with the ipsilateral aid, some hamstring flexibility exercises, hamstring stretch with pelvic stability, and a single leg RDL to eccentrically lengthen the hamstrings. Then some anti-flexion stretches, bird dog and bear crawl. For the hypolordotic and extension intolerant postures, I want to do some anti-extension exercises to activate the anterior core. So for those, I'm going to do the isometric dead bug on the Bozu, as well as the stability ball plank. I also want to do some glute activation exercises. That's going to involve, once again, the glute bridge, sagittal plane banded walks. And then I want to lengthen those superficial hip flexors. So I'm going to do a superficial hip flexor stretch, which is a rear foot elevated hip flexor stretch. And then for my lumbopelvic and rotary instability, I think it's important to turn on that glute med. So we're going to do some glute med activation exercise. For that, I'm going to do some modified side plank with a clam. That's going to be with a band. And then also some standing banded internal and external rotation pulses. For my core activation for lumbopelvic stability, I'm going to do continue with the dead bugs on the Bozu. And I also want to do the plowing the field core bracing exercise with the hamstring variation to also get some length in the hamstrings because they're already tight. And then for rotary core stability, I'm going to implement some shoulder tap as far as the corrective exercise, and then some half kneeling, some tandem half kneeling position with some perturbations, the bully exercise to get some frontal plane and some transverse rotary stability as well. And then as far as my lack of shoulder mobility and that minor failure of the shoulder clearing test, I want to do some scapular stability exercises to kind of help with the upward rotation of the scapula. So for that, I'm going to do the push-up plus on the stability ball, the scapular pull-ups working on the depression, the single arm high to low row also working on depression, and those prone T's and Y's to really get those scapular retractors in that lower trap activated. And the final compensation was that single leg instability. So for that, I want to do some single leg stance balance and proprioception exercises. So for that, I'm going to do single leg RDL and then a single leg balance with a clam to get that glute med firing as well, and then implementing some reactionary tasks like a ball toss. And I also want to do some intrinsic foot muscle stabilizations. So for that, I'm going to do the short foot exercise that we learned in the corrective exercise video, as well as some short foot posture with some reactive neuromuscular training, which is just going to involve me holding my arch and then having a band pulling me in either pronation and supination to make sure that my foot is stable in that position. And that is my initial video. Thank you for listening.